So now, without further ado, it is my pleasure to get to today's webinar on food allergy testing basics. We had an overwhelming response for this webinar, and I think it just speaks to the topic and how important it is to all of us. So I'd like to welcome both of our speakers today, Dr. John James and Dr. Gary Falsitano. Their disclosures are listed on this slide, but they're going to be introducing themselves today. So without further ado, I'm going to hand it over to Gary, and thank you both for being here, and thank you all for being here with us for this next hour.
Well, thank you so much, Kelly. And I'm not a doctor, I'm a PA, but I'm a clinically trained PA. I've been in practice for over 25 years. My background is fairly eclectic in both primary care, emergency medicine, some military medicine, as well as disaster response. For the last 11 years, I've been in allergy and immunology. Currently the U.S. Scientific Affairs Manager for Allergy at Thermo Fisher Scientific. And Thermo Fisher Scientific is actually the manufacturer of some of the allergy diagnostics that are used throughout the world. So the immunocap diagnostics are actually used in greater than 80% of the laboratories around the world. One of the best parts of my job is I work with researchers and I work with leading allergists and immunologists throughout the country, throughout the world. And one of those allergists is my co-presenter today. And I'd like you to meet Dr. John James. And John, why don't you introduce yourself?
Thank you, Gary. Can you hear me?
Absolutely.
Great. I wanted to thank Kelly Cleary so much for being the moderator of the staff at FAIR, and Gary for being the co-moderator. I'm a board-certified allergy immunology specialist. I've been in the practice of clinical allergy immunology for over 30 years, both in the clinic and more recently as a consultant. I trained a medical degree at the University of Tennessee in Memphis, did my pediatric residency in Utah, and I did my allergy immunology fellowship at Johns Hopkins. And I've listed some of my experience there. I'm very active in our professional societies, both local and national. So the agenda is listed here. We'll provide an overview with epidemiology and impact of food allergies, move into adverse food reactions with several definitions, immune versus non-immune, food allergy versus food intolerance, and some diagnostic dilemmas. And then we'll talk about diagnostic testing. Gary will take over this part of the talk. Whole allergens, molecular component allergens, provocation testing, evolving diagnostics, and improving testing. I wanted to just mention here, in our webinar in August 16th, we're going to go into a lot more detail in oral food challenges and evolving diagnostics. So I just wanted to mention that at the front end. So we'll go to the next slide, Gary. So food allergies, as many of you know well, is a serious health problem. 32 million individuals in the United States have food allergy, and this impacts people all around the world. There's been an 18% increase in the prevalence of food allergy over the past 2 decades. That's a whopping increase. And 1 in 13 children, or about 8%, have food allergies. 3% of these are severe, including anaphylaxis, and 2.4% of these children have multiple food allergies. Also, 10% of infants have food allergies, and up to 10 to 11% of adults have food allergies. We have two these are references, and I'll just summarize the findings here. And the first one, the public health impact of parent-reported childhood food allergy in the United States. The estimates of current food allergy prevalence are 7.6% in children. Most prevalent allergens, as many of you are aware, are peanuts, cow milk, shellfish, and tree nuts, and the percentages are listed there. This next article is JAMA Open Access article. You can access this on the web easily, and this was done by Ruchi Gupta and her colleagues at Northwestern. They did a survey of over 40,000 adults and found the food allergy prevalence among U.S. adults was 10.8%. And the most common allergens were shellfish, cow milk, peanut, tree nuts, and finfish. So more than 1 in 10 adults have reported food allergy. Approximately 26 million adults Peanut allergy affects over 4.6 million adults. The prevalence of peanut allergy is about 2% in the United States, which is really that's really a notable figure. And I wanted to point out that over 50% of food allergic adults had at least one adult onset food allergy. So they didn't have any food allergies as an infant, a child, a teenager, but when they got into adult, they might have developed a peanut allergy or a shellfish allergy. This is very significant.
Yeah, John, I was surprised by that in this study, right? We tend to think of food allergy as being very childhood centered, but I think, when we really look at the numbers now, it very much is an adult disease as well.
And we're learning more and more. There's much more research being done for adults with food allergies than was done during my early part of my career, in my fellowship, early allergy practice. This was most of the focus was on children, infants and children, definitely eerie. So the big 9 food allergens are listed here. Most all of you on this webinar are going to be familiar with these. 9 foods account for 90% of food allergic reactions. The major ones being egg, milk, peanut, and tree nuts, but we also have listed here soy, wheat, finfish, and sesame was the most recently added.
Yeah, this used to be the big 8, right? And now we've got the big 9 with
correct.
sesame.
And in labeling, this is a huge issue, as many of the people on this webinar are aware of. So the impact of food allergies, we've known for a long time that approximately a third or 30% of children with moderate to severe atopic dermatitis have an underlying food allergy contributing or playing a role, not the only factor for atopic dermatitis, but this is especially children whose their atopic dermatitis or eczema is hard to control with typical medical therapies. So what is the social impact of food allergy? And this is gaining a lot more attention over the past decade or so. So children with food allergies can be bullied at school or in other venues. Their diets definitely can be restricted. They can be misunderstood by family, by relatives, by friends. They don't necessarily have a good background or understanding of what food allergy might be. It can lead to anxiety, other psychological effects, and they could feel isolated from their friends, from their school, from activities, et cetera, from big events. So it's a very huge social impact, and much more research is being done on the psychological aspects of food allergy, which is great.
Yeah, agreed.
So we need to have a balance between health and happiness and what these families and these patients have to go through. Hypervigilance, we need to read labels. We need to pay attention when we're traveling. We need to pay attention at schools. Relatives need to be aware of this. So when the child is going from one home or daycare or schools or other family members' homes, versus a person who does not have a food allergy, an unrestricted diet. So what about the overreporting of food allergies may promote unnecessary avoidance measures and restrictions? Well, the public perception of food allergy is about 20 to 25%, much higher than the actual prevalence that we covered on other slides. So down to 10% or less. But there are a lot of people who think they might have a food allergy, just don't understand what a food allergy might be versus a food intolerance. And so that can be much higher than when you go through the history, the testing, and food challenges, it can be much less.
So tell us a little bit about the difference, John, between food allergy and food intolerance.
Yes. So, and this is one of the sort of the most important parts of this talk, I think. Food allergy is defined as an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. So it will require avoidance of that specific food allergy, like a peanut allergy or a tree nut allergy. These can cause serious or life-threatening reactions, such as anaphylaxis. Not in all cases, but a certain percentage of food allergies can lead to anaphylaxis. And allergy medications are needed, epinephrine being the main gold standard treatment for anaphylaxis. And the examples would be peanut allergy, tree nut allergy. These are caused by an IgE mediator. We'll talk about this later, but there's a specific immune response that is underlying cause of this food allergy. Now, this is in opposition, or on the other hand, to food intolerances, which are non-immune reactions that include metabolic, toxic, pharmacologic, and undefined mechanisms. We'll show in the next slide. These are managed by specific food avoidance measures and being aware of like labels and what's in a food or in a buffet, et cetera. And it's typically a digestive system reaction. So nausea, vomiting, diarrhea, abdominal bloating, abdominal pain. And lactose intolerance is by far the most common example of a food intolerance, and this is not a food allergy. So this is a typical diagram you'll see in the medical literature or in other presentations, adverse food reaction being the umbrella, and that's broken down into the immune-mediated reactions and the non-immune mediated reactions. And examples would be to the far left is IG-mediated reactions like peanut allergy or tree nut allergy that can cause acute reactions such as hives, swelling, even oral allergy syndrome, so and anaphylaxis that we mentioned. There are non-IgE mediated reactions, which would be like protein-induced enteropathies. Celiac disease is an immune-mediated food allergy reaction, but it's not mediated by IgE. It's more of an autoimmune type reaction. There are mixed IgE and non-IgE reactions, eosinophilic gastroenteritis syndromes you may be familiar with, and then cell-mediated reactions like allergic contact dermatitis. And like on the other hand,
poison ivy, right, John?
Oh, yes. And this could be, poison ivy would be a classic example of an allergic contact dermatitis or nickel allergy being a cause. And some patients with nickel allergy have problems with soy, so that kind of fits there. In the non-immune reactions, we have lactose intolerance. It's a metabolic, a lack of an enzyme in the gut. Caffeine can cause pharmacologic effects. Scromboid poison is a problem with fish being spoiled, and if you eat it, you can have reactions like flushing and itching. And then sulfites, which are regulated now to not be in foods that can cause respiratory reactions like asthma, etc. So this is a complicated slide, but the spectrum of food allergy, again, IG mediated. These are more the immune mediated reactions. So this is going to play a role in the history where we're talking about what are their symptoms. So skin reactions, hives. Skin reactions are the most common with IG-mediated reactions, hives and swelling or angioedema, respiratory symptoms, cough, wheezing. Food allergy is not per se a real common cause for asthma, but it causes respiratory symptoms that can be seen in asthmatics. GI symptoms, systemic anaphylaxis, food-induced, exercise-induced anaphylaxis. And then in the middle are atopic dermatitis, so that's a skin rash, eosinophilic gastrointestinal disorders like eosinophilic esophagitis, and to the far right would be the cell-mediated reactions, certain rashes, and other disorders that involve the gastrointestinal tract. I wanted to point out disorders that some people think are related to food allergy, but have been proven with medical and scientific and research studies to not be related to food allergies. Migraine headaches, behavioral developmental disorders, like hyperactivity, arthritis, seizures, and inflammatory bowel diseases. Now, patients might see an association of food that may be associated with some symptoms, but there's not an immune mediated or immune underlying cause that brings on these disorders. So not food allergies bringing on these disorders. Natural history of food allergy, about 80% of individuals with cow milk, eggs, soy, and wheat allergy will remit by teenage years, sometimes earlier, and sometimes the declining or low levels of specific IgE to food allergy can be predicted. Cow milk and egg allergy tolerance to extensively heated proteins can precede the development of tolerance, and Gary's going to talk about this later. There's a high likelihood of developing other allergic diseases, and this is the atopic march. So patients may develop allergies to other foods. They may develop allergic rhinitis or hay fever, and some can develop asthma. So this can be a marker for other atopic diseases that develop later. And then non-IG mediated GI disorders like food protein-induced enterocolitis. Some of these patients can have their symptoms resolve or their disease resolve in 1 to 3 years after diagnosis.
Thanks so much, John. So, you really did a great job of talking about the spectrum of adverse food reactions. And I think that really leads us into, how do we make the diagnosis? And we're going to specifically concentrate on the IgE mediated, right, what are otherwise known as type 1 hypersensitivity reactions to foods. But we know there is certainly a full spectrum of other non-allergic causes as well. So, when we think about, the title of this webinar is food allergy diagnosis, 101. So when we get back to basics, the most important thing that we can do when we're trying to sort out an adverse reaction to a food, it really comes back to the history. And we can't say that enough. We have very good diagnostic testing, but diagnostic testing alone will not diagnose an allergy or even some of the other non-allergic causes of reactions. It really comes back to doing an excellent history and then correlating that history with diagnostic tests to come up with a diagnosis. One of the things that our listeners can do is really be prepared for your visits, whether you're speaking with your pediatric clinicians, whether you're speaking with your specialists, your allergists. It's really important to keep these things in mind and have these, because we often forget, have them written down so that you can bring this information and really help your clinicians get to the right diagnosis. So, looking at the signs and symptoms, what type of reactions did you have? What was the timing of the reaction following the ingestion of the food? That can be very important. There are some allergies that are actually delayed. Almost all IgE-mediated reactions happen quickly, certainly within the first hour after ingestion or two. But there is an IgE reaction called alpha-gal that some of you may have heard that is actually a delayed reaction. So that can be part of kind of assessing whether this is an allergy or not. A lot of the intolerances are more delayed reactions. What type of food you ingested, whether it was cooked, whether it was raw. And then does it happen every time you ingest the food? If not, is it related to something else, things like exercise or having a viral illness? And then finally, what did you do? Did it just go away? Did you take an antihistamine? Did it require epinephrine? These are really important historical points that are very important to let clinicians know to help them get to the right diagnosis.
Gary, I would add one thing. I would stress one thing, that sometimes patients come in and they've done testing without any history being taken or any evaluation by a healthcare provider, and that should really not be done, because the history is so, put that in context with the testing, as Gary mentioned, is so important. So don't be, you could be wary if people are doing testing and just not knowing how to interpret that testing. That's all I would say there.
Yeah, I think that's a great point. And we always start our evaluations, right, with history, and then we base the testing on that history. So excellent point. We're going to talk about various types of testing today. Some we're going to go into more detail than others. In our second webinar that'll be on August 16th, we'll go into more depth onto some of these as well. But our key diagnostics that have been around for quite some time are the skin prick IgE testing done by the specialist, specific IgE blood testing, which is done by specialists and primary care clinicians alike, component resolved diagnostic testing, which is a form of the IgE serologic testing, but looking at more specific markers within those specific allergens that we're looking at. Also looking at some evolving diagnostics, which we really won't discuss today, but some of them are functional assays like basophil activation testing and a newly emerging epitope pattern analysis. These are both kind of future diagnostics, and I think we're going to see them playing even more of a role as almost a tertiary type of testing to really help us sort out when we still have questions after initial history and initial testing. Oral food challenges remain really the gold standard of diagnosis. Double-blind food challenges, which are usually just done in research, are really the gold standard, but oral food challenges done in clinical practice are very good tests to prove prove or disprove an allergy. The issue with those are that they can sometimes cause an acute severe reaction. So we want to be mindful of when we use them and using them appropriately. And then finally, John will finish up today talking a little bit about some of the unproven tests that are out there and what we really need to stay away from. So, when we think about specifically testing for IgE, we do it two ways. I mentioned serologic testing on the left, and then skin prick testing on the right. Both measure IgE in different ways, but they also both are sensitization tests. And what that means is when we have a sensitization, that means we have the potential for allergy. That does not mean we have an allergy, which is, again, going back to why we really need to correlate the results of these tests with symptoms and the entire history, and that's how we get to a diagnosis. So, in general, in medicine, when we're making a diagnosis that requires testing, we look at what we call a pretest probability. What's the likelihood, based upon the history, that someone has this disease or condition? Then we do a test, and we change that pretest probability to a post-test probability. Again, a test is not, especially an allergy test, is not a conclusive, 100%. It requires interpretation, which is why it's so important to be with, and to utilize clinicians that understand this. So when we talk about specific IgE blood testing or serologic testing, we know that the higher the number, the larger the result, right, the more likely you are to have symptoms. The same thing is true with skin testing. The larger the reaction on the skin, the more likely whatever we're testing is the cause of your symptoms. What it doesn't tell us is severity. So you can have a very high number or a very large skin test, and either have no symptoms or very mild symptoms. You can also have a low reaction and have severe symptoms. So the diagnostic testing, again, the higher the number or the larger the reaction, the more likely that's what's causing the symptoms. Now, there was some really seminal work done back in the late 90s and early 2000s done at Mount Sinai in New York around kind of finding decision points for specific IgE testing. And these have been used really for the past 2 decades as kind of a starting point, right? When we look at food allergy testing results, specific IgE results. Now, they were done in a specific population, right, in a tertiary care center, in a food allergy center. The children all had atopic dermatitis, pretty severe. So it's a certain population, but we've been able to use these numbers to help us predict who might react depending on the results. You can see with egg greater than 6, peanut greater than 15, there's a 95% probability that someone will actually have a clinical allergy or reaction. On some of these in the gold or yellow, depending on how it's appearing on your screen, there's a 90% negative predictive value. So people with a level, to milk of below 1 have a 90% chance of not having a clinical reaction to milk. Now, these again are just some, we kind of call them kind of parameters that we use, and there are certainly a lot of gray areas here, which is why we need history, and also why I'm going to talk about in a minute how components or allergen components can really help us add to our kind of the information available to help us better predict what type of clinical reactions may occur. So going into a little bit more depth around skin testing, and then we'll talk about the in vitro blood testing. Skin testing is our oldest diagnostic test for allergy. It's been around since the late 1800s. It's a very reliable test. It's done by allergists, throughout the world. The available extracts are mostly commercially available. Some of them are standardized, some are not. And then we also use extracts that are prepared on kind of in the moment, right? Extracts of fresh foods that give us additional information that may be lost during processing of the commercially available food extracts. A series of punctures are made on the skin. We look for a reaction, both a raised wheal and also what we call a flare or area of redness. And then, as I said, the larger the reaction, the more likely that we actually, that's going to be causing the symptoms that we tested for. Typically, those reactions have to be larger than 3 millimeters. It's a very safe procedure. There's a very low risk of any type of allergic or anaphylactic reactions, although there is a small risk, and there is minimal discomfort involved. One drawback of the skin testing is that patients have to be off certain medications, such as antihistamines. So they need a kind of a washout period in order to get an accurate test. With blood testing or serologic testing, again, this has been around for since the late 1960s, early 1970s. The technology involved has really progressed to the point that blood testing is really considered clinically equivalent to skin testing. There are also allergen components, which are molecular diagnostics that allow us to take a little bit deeper dive and understand what may be actually driving those positives that either are or aren't responsible for symptoms. They are very highly reproducible. They're standardized. Positive result is anything greater than 0.1. And again, the greater the number, the more likely that that's what's driving symptoms. There is minimal patient discomfort here. It requires a blood draw, but medications do not affect these results. So these tests can be done regardless of whatever medication you're on. And actually, both tests can be done regardless of the time of year or the relationship to when you've eaten a food. Those antibodies are there whether you've had a recent exposure to the allergen or not. And then finally, kind of in summary, looking at both the skin testing and the serum blood testing, it's really important to understand that these tests have some limitations. They are very good negative predictive tests. So if you have a negative result, we can be fairly confident, actually with a high degree of certainty that is not causing your symptoms. If you have a positive result, that's where we really need to take history into consideration and kind of look at the prevalence in the population that you come from, look at your history around specific allergens and what's happened when you've ingested them, and then potentially even use component resolved diagnosis to understand those positives a little bit more. So the biggest issue with both skin and blood testing is people thinking that a positive result, no matter what it is, means we have an allergy, and that just isn't the case. And as Dr. James mentioned earlier, we really want to test based upon history. We don't want to do these large indiscriminate panels of hundreds of allergens. We'll get back a lot of these elevations that probably are not clinically relevant, and that's going to cause people to pull foods out of their diet that that really need to be there. We don't want to cause malnourishment, right? There are also other tests that are not IgE tests, and Dr. James alluded to some of these that are done. Some are available, that you can do at home on your own. These are called IgG tests. That's a different antibody, and those have, we'll talk about in a minute, really have no clinical relevance to true food allergy, and they can cause a lot of confusion. And then, finally, with this testing, it's really important that pediatrician and family practice clinicians understand food allergy, and a lot of them do. A lot of them are kind of evolving because they have to. There are a little over 4,000 allergists in the country. Dr. James mentioned there's about 32 million people with food allergy. We really need all hands on deck to really understand food allergy and to treat it appropriately. So before I turn it over to Dr. James for kind of clarifying some of our other testing modalities, I just want to talk about what the paradigm, right? What the testing paradigm has been like for quite a while. So we mentioned you have to do a really good clinical history. Then we typically test with those whole allergens, whether that be skin testing or blood testing. Then if indicated, and we'll talk about this again on our webinar on the August 16th, a food challenge may or may not be appropriate, especially if we're in an area where we have an unclear history and we have test results that are really not convincing. a food challenge may be the best way to figure out if someone can tolerate a food, and then we can use personalized management. In a minute, I'm going to talk about testing with allergen components and how that gives us additional information to help really guide those food challenges and a better understanding of how a patient or someone might clinically react after eating the food. So John, can you take us through kind of the testing that's involved? I think we talked a little bit about specific IG, but also on non-IG mediated and some other non-immune causes.
Sure. So there, I want at the very top is suspecting IgE mediated, which Gary covered very well. Suspecting non-IG mediated, well, if someone is thought to have celiac disease, there's blood testing to screen for that, autoantibody specific, and then biopsy of the small intestine or the skin, because they can have dermatitis or pediformis. And other diseases like eosinophilic esophagitis, there's going to be an upper GI endoscopy and biopsy of the esophagus to, first of all, identify is it EOE or not, and then foods are not always the culprit there, so it can be very challenging. And then in a food intolerance example was lactose intolerance. There is a hydrogen breath test that can be used to make that diagnosis. Endoscopy can be used. Sweat test is more for cystic fibrosis, which sometimes people think they might have a food allergy contributing to that.
Great, thank you. So, getting back to IgE mediated and allergen components, I think probably the best way to understand allergen components is really to go back to one of the tests that I think we're all familiar with, and that's the cholesterol testing for hyperlipidemia. For years, we only had total cholesterol testing. And then, we were able to, the research has been able to identify certain subtypes of cholesterol that were a lot more informative. HDL, LDL, triglycerides, I think we're all pretty familiar with those. HDL obviously being one of the, the more positive markers, right? More reassuring markers, LDL being, what we call the bad cholesterol, and triglycerides, not being, one of the good markers either. But looking at that total cholesterol, it sometimes gave us an incomplete picture that those HDLs, LDLs, and triglycerides really filled in for us. And we even have additional testing now, past those. It's the same thing when we're talking about whole allergens, and whether those whole allergens are assessed by skin testing or blood testing. They give us a big, broad picture of potential sensitizations and potential allergy, depending on symptoms. Components can give us a little bit deeper dive and really, help to complete this diagnostic puzzle that we're trying to figure out whether someone is truly allergic or not, or they just have an elevated result that may or may not be relevant. So, when we talk about components, I'd first like to just kind of mention egg and milk components were the first ones to be cleared by the FDA in the early 2000s. And with egg and milk components, it's really about the stability of the proteins within them. So we know that, in certain studies, we've seen 70% of patients who are sensitized to egg, so have a positive, either skin or blood test to whole extract egg, may be able to tolerate baked egg. And, there are certain, certain clues that indicate whether that could be the case or not. And one of them is looking at the individual proteins. So there's two proteins in the egg that we currently look at, ovomucoid and ovalbumin. And without getting, super in the weeds or into, molecular structures, ovomucoid is a very strong kind of molecule that is unable to be changed by heating. So what that means is if you're sensitized to ovomucoid, you're probably going to be sensitized to all forms of egg. However, if you're sensitized to ovalbumin, highly heating it, baking it for a period of time, as you would do with, say, a cupcake, really denatures that protein and allows you to potentially tolerate it, so in the baked form. So, having this kind of molecular profile that's negative for ovomucoid is more reassuring that you could tolerate baked egg products. And I think probably the best way to look at that is a quick case study. So this is a very common situation that we see. This is a 2-year-old little guy. He's been suffering from, atopic dermatitis, eczema since he was little, even littler. Now at his 2-year well check, his eczema is still there, still present, but he's also having intermittent GI complaints, and we can't really figure out what's going on. So some testing is ordered by his clinician. And you remember these positive predictive values that we talked about earlier. His egg actually comes up at around 3.7. So that's kind of in that gray area between positive and negative predictive value. It's a significant result, but it really doesn't tell us whether he's going to be able to tolerate baked egg or not. When we look at his individual component results, we see that there's his total egg white at 3.7. We see that only ovalbumin is elevated. So again, looking at that little diagram on the bottom, ovalbumin can be denatured. So what his clinicians decided was that this is a perfect candidate for a baked egg challenge. It was sent to the specialist, had a baked egg challenge, passed, and now is able to start consuming baked egg products like birthday cake or cupcakes. And they'll reevaluate him because, as John said in the natural history of disease, most people's allergy to egg and milk and certain other allergens will resolve by the time they hit adolescence. There have been studies that have shown that introducing baked foods like baked egg into the diet early may hasten that tolerance, so may hasten their ability to start tolerating all forms of egg. There's a very similar story with protein stability with milk. I'm not going to go into the specific proteins. We'll do that on the 16th. But just know that it's the exact same story. About 75% of patients who are sensitized to cow's milk, whole extract, could potentially tolerate baked milk, depending on the proteins they're sensitized to. And now we'll kind of just change gears a little bit, and we'll talk about some different allergens, peanuts and tree nuts, and how cross-reactivity comes into play when we see positive results that may not have clinical symptoms. So, when we talk about cross-reactivity, we're really talking about proteins in different sources that look the same. So there are proteins in the peanut and proteins in birch tree and other similar trees' pollen that look very, very similar. And what that means is if you have an allergy to birch pollen, so you have, allergic rhinitis, symptoms in the spring and it's from birch-like trees, those proteins you've produced antibodies to look very similar to some proteins in the peanut that you can also produce antibodies to. So in that case, a birch pollen allergy can actually cause us to have a positive peanut test. And that test is usually not indicative of a severe allergy. And I'll show you that in a second. We know that there's a good number of people, if we just take all comers, that are sensitized to peanuts that are not at a risk for a severe reaction or an anaphylaxis. The question is, how do we figure that out? Do we do oral food challenges with all of these patients? Well, we'd like to be, sure that when we do a food challenge, we're actually, the patient has a high probability of passing. And that's where the components can really come into play. Remembering that, as John mentioned, overdiagnosis can result in unnecessary anxiety. Food allergy that's actually confirmed, is enough to worry about. We shouldn't be worrying about things that really, when we don't have an allergy. As I mentioned, whole allergen testing has a very high sensitivity, which means we're not going to miss any food allergies, but we may have positive results that may not be true food allergy. So that's where the components can come in to really improve our specificity and knowing, that something has more of a likelihood of actually causing a true clinical reaction. And this is a nice kind of Venn diagram of kind of showing how sensitization to birch pollen or peach pollen or olive pollen, there are certain of those proteins that may cause a peanut to be positive. You can see there in the yellow or the gold, the birch pollen protein looks a lot like a protein in the peanut, and the peach pollen protein there looks a lot like the pollen in the peanut as well. Both can cause positive tests, but with a lower risk of systemic reactions. So with that, I I'm going to turn it back to John. John, if you could take us through this case, and then I'll come back and maybe we'll discuss the results. I think this really helps to crystallize how components can be helpful.
Sure. And in lieu of time, I'm going to maybe go a little faster because we want to have time for questions at the end. So this is a patient who suspected to have peanut allergy since age 2. There was a family history. The father had peanut allergy. This infant was tested, and the past medical history has had diagnosed with food allergy by testing really at 2 years of age because the father was allergic and had anaphylaxis, and has strictly avoided peanuts since then. So he's currently a senior in high school, potentially a D1 football player, applied to colleges, hoping to go to one of the military academies. But this happens in my practice many times. The academy would rescind that application due to an allergic condition such as peanut allergy. And he had siblings diagnosed with peanut allergy. He was on a multivitamin. He had an EpiPen autoinjector.
Yeah, so I guess, before I go on, I guess, the real question here is, okay, so he was diagnosed as a child, and he had, fairly significant positive tests, 16, 17 years ago. But now, he's avoided peanut his whole life. Hasn't really been an issue for him. It's now a really big issue, right? To figure out whether he is truly allergic or not. And this is an actual case. I've spoken to both the patient and his mom. His mom was very adamant in helping him kind of get to the right diagnosis. So after doing some research, they went back to their allergist that they had been seeing all along. The allergist said, well, you know what? We have additional testing now that we didn't have 18 years ago. Let's see what your peanut components, allergen components, actually look like. So his peanut, they did skin testing that was significantly positive. His peanut blood testing was, pretty high. I mean, when we look at a level of 14, this is, that's a concerning level. It doesn't necessarily reach the 15 that we talked about in those positive decision points, but it's a concerning level for sure. When they got back the individual components, what we see is, remember that birch pollen-like protein in the peanut, it's actually known as RH8, was significantly elevated. So that's now starting to get reassuring because we don't see any of the severe proteins in the peanut being elevated. So these severe proteins, the RH1, 2, 3, and 6, are highly correlated with symptomatic allergy. So this patient, when we see the rest of his results, he has another elevation of RH9, but not very high at all. And that's kind of a variable risk protein. And then his highest elevation of components is actually with profilin, which is a very, very benign type protein. It is rarely associated with actually food allergy. And if we look at these components on a risk ramp, kind of from the left to the right, being the least likely to cause a reaction being these CCDs and profilins. The PR10 is what we talked about with the birch pollen, and then the other families, LTPs and storage proteins, as we get to the right, being more and more associated with allergy. And we see the profilins were really high, as I mentioned. His PR10 was high as well. He had a very low level to LTPs, and he has no sensitization to the storage proteins. So this put him at a very low risk of potentially having a severe reaction. So the next step was for him and his allergist is to actually have an oral food challenge because he was at low risk. He ended up passing that food challenge without any symptoms at all. This is actually the note that was written to the military academy that says he is not allergic to peanut. They recommend he ingest peanut every day, as a matter of fact. He, as a side note, loves Uncrustables and eats them pretty much every day. So this is how components can help us be more confident in who to test and who to food challenge and give us a better idea of what those results are going to be. There are additional components for tree nuts, not depicted here. There are additional components for wheat and sesame. We mentioned sesame being an emerging allergen. when we look at those storage proteins there on the right, those are all really raise our suspicion, especially when they're elevated, and especially when they're elevated at higher levels, that someone has a true clinical allergy, and we need to be careful when we look to doing additional testing, such as oral food challenges. We'll talk more in depth at the next webinar of these in particular, and then some other diagnostic tests as well. That really concludes our look at allergen components. But John, can you take us through some of the things that are not recommended for us to be testing for?
Sure. And before I go to this, I think some of the most rewarding clinical cases I've had are the one presented there with that peanut allergy, and a patient wants to go to the military, and clearing those are so satisfying and rewarding for the physician and the family.
It really has a lifelong impact, right?
Oh,
Yeah.
yes, and it's such a great thing to be able to do that, play a role in that for the family and the patient. So the testing that's not recommended, the most common would be the food-specific IgG and IgG4 testing that Gary alluded to. And sometimes people get these broad panels of these, like hundreds of foods are tested with these IgG. And this is where it's so important to see a board-certified allergist who can walk through what has been done, go through proper history, proper interpretation, proper testing, et cetera. I can't stress that enough. Some other improving testing are sublingual testing, lymphocyte activation, cytotox testing, or the applied kinesiology or muscle testing, and electrodermal testing. I can't go into detail here because of time, but I wanted to list some of these so it's very appropriate to talk to your healthcare provider and an allergist to make sure you're going down the right path and not having foods restricted based on unproven testing.
So speaking of that, what are some good reasons for an allergy referral, right? When to ask for it, certainly, and if there's primary care providers watching, what are kind of some good areas to
Sure, and this is sort of going to conclude what we're talking about. A known food allergy diagnosis for ongoing management and follow-up, possible development of tolerance. We have talked about that today. Having a correct action plan, an epinephrine, how to use it, when to use it. When food-specific IG level is undetectable in a child with a convincing history of an immediate type allergy. This happens. And those tests are not 100%, and that's what we talked about earlier. A known diagnosis of food allergy with increased risk of other allergies to other foods, say an egg allergy, then they develop an allergy to a tree nut or to shellfish. When infants develop different forms of eczema refractory to treatment, those patients would really benefit from an allergy consultation. Allergic or atopic families who have expecting a newborn, who are interested in identifying risk and prevention of food allergy. Child with peanut allergy, there's about a 7% increase risk of another sibling developing peanut allergy. And evaluation for possible food allergy. So there's a lot of reasons that would be an appropriate referral to an allergy specialist. And I think a lot of mileage can be gained by doing a proper assessment with someone who is trained appropriately in the evaluation and management of food allergy.
I think that's a great point. And, you mentioned kind of the early introduction. And I think, we've seen that, the research has really demonstrated that we need to start feeding children early potentially allergenic foods. And sometimes parents are a little reluctant to do that, even when their pediatricians are recommending it. So I think that's a perfect time to involve an allergist and kind of get reassured that you can start introducing those foods into the diet. So John, let's summarize.
So we talked a lot about the history. We didn't really talk about physical exams. It's mostly the clinical history, unless there's eczema. Testing, we certainly covered in detail. Other diagnostic testing, I think I just want to again mention that upcoming second webinar in August, I'm going to be involved with that one. We're going to dive more into the other diagnostic testing, and then food challenges. We'll also talk about there. We talked about avoiding unproven diagnostic tests.
Yeah. Well, thank you very much. This has been certainly a pleasure and an honor kind of co-presenting with you. I think before we get to questions, I would just say, if my biggest kind of take home for everyone is really to, to be empowered, right? With your parents and you have food allergies, potentially food allergic children, or your adults, and you're really trying to get to the right answers, make sure you keep pushing and find clinicians that are very, very well schooled in this, and really be your own advocate for sure. And with that, I'll turn it back to Dr. Cleary, and maybe we have some questions.
So thank you both. That was fantastic. And I cannot tell you how active the Q&A was. So this has been a really engaged audience with tons of questions. So I'm glad that we have some time for questions. And I think that the questions really emphasize a lot of the things that you've both highlighted, and just really reflect how important this topic of diagnosis is and how confusing it is sometimes for families. So just to get started, Dr. James, this is jumping off of something that you had mentioned about, and Gary, that you reiterated about really seeing someone who is specialized. We've had lots of people in the chat bringing up that on first glance of all of their blood work, they are told to avoid so many different foods. And then when they see someone more specialized, they're telling them that they can start introducing other foods. So can you walk a family through that? And again, I know we talked about that broadly in this webinar, but really walking them through to understand how that is the case where two physicians may differ in their opinions.
Sure. So I think knowing what type of test it was is extremely important. And also going back through the history, because sometimes they'll bring in these tests that have positive results, but you go through their history and they're eating that food with absolutely no symptoms. So that is critical. That's critical to not go down the path of restriction when they're eating the food with absolutely no clinical symptoms. And knowing that the number of food allergies is I talked about this over the prevalent of people think in the general public, there's a much higher thinking that there's 20 to 25% think they might have food allergies, but when you go through the history, the workup, et cetera, it's much less. So we got to get to the right diagnosis. You got to have people who are comfortable, who are trained, that understand how to go through this process, which we've talked about several times.
Yeah.
Yeah, that is exactly what I think the point home is kind of getting to the right allergy team and really understanding. And Gary, I love what you had said earlier about really just asking the questions and advocating for yourself, your family, and anyone else. Gary, this one is for you. We had a couple of people in the chat ask, is there an age limit or an early age limit on how old someone needs to be to get component testing?
Yeah, no, absolutely not. So it's indicated for patients of any age that have, symptoms consistent, right? So we don't test if you don't have symptoms, but no, the components can be tested at any age and have been, both in research and in clinical practice.
Another hot topic that has come up in the Q&A has been the thought of outgrowing allergies. So maybe you can both give us a little bit of an idea of what is the likelihood of outgrowing an allergy, but then also how can diagnostics help us in determining if someone's outgrowing an allergen?
Well, I'll start with what we know at this point in time. We know, on one of the slides I showed, like egg, milk, wheat, and soy, we know that up to 80% of those individuals can develop tolerance over time. It may take into childhood or a little later for that to occur. Once you get past into the teenage years and they haven't developed tolerance, it's very unlikely that will happen. On the flip side of peanuts, tree nuts, shellfish, there's a much lesser chance of those individuals. So like peanuts, about 20% of those will develop tolerance. Shellfish and tree nuts, 10% or less. So we have to have that information because parents are asked. This is a very common question that parents ask in the clinic.
Yeah, and so I for the second part of that question, as far as diagnostics, I think one of the things we've done for quite a while is follow patients' levels over time. So seeing those decreasing levels get to a point where we say, you know what, maybe we need to try and see if you're going to react to this food when you get to a certain level that's, you know, more comfortable. Components can help with that as well. Looking at those levels coming down, or components, you know, kind of disappearing. And then finally, you know, as I mentioned when we talked about the egg and the milk, by incorporating the baked foods into the diet, if they can tolerate them, there is some evidence that will hasten tolerance as well.
Absolutely. Great point, Gary.
That's great information. And to that point, is there a cadence that you would recommend patients following? Is this, if someone has a known allergen, is this something that they should be revisiting every year, every 2 years? What's your recommendation?
John?
In general, we typically would say yearly for the evaluation. We don't want to do too much testing if we, you know, it can be expensive. But I think yearly, but some patients are very severe and have other atopic conditions like asthma and eczema. We're seeing them more frequently, maybe every 3 to 6 months. But in general, yearly is sort of the standard.
And in our last minute, I would love for both of you to give our participants just a take-home point on, you know, if you or your child has been diagnosed with a food allergy, what's the question that you would want to be asked, you know, or you would advise them to ask their allergist at their next visit?
I'll touch on what Kelly and Gary mentioned, and that is, I think patients, I like it when patients are educated, they educate themselves, they're very empowered. It's shared decision making. It's the whole piece coming together. You don't want the provider to just be dictating to you what can be done. You want to have your questions ready. You want to be educated. Come to these conferences. This is a good step. It's a very actionable step. So I think, don't rely just on testing. Be prepared. Educate yourself. You can never. It's so important.
Gary, any last advice to our listeners?
Yeah, I think that, you know, that's such good advice. It's so important to keep asking the questions, right? And until you're sure you're at the right diagnosis, and not accepting, and again, because providers have a vast, experience level, right? And some are extremely knowledgeable around food allergy, and some are less so. So, you know, make sure that you're getting to the answer and you're comfortable with that answer before you potentially change your life based upon a diagnosis.
Absolutely.
Well, thank you both. This was a fantastic webinar. I want to thank Thermo Fisher Scientific Allergy Insider for sponsoring this. And, you know, one more plug for the August 16th webinar, which will be part 2 of this diagnostic series. And we can see how important this is and how many questions we as a food allergy community really have surrounding diagnostics. So please share the August 16th webinar and join us. But thank you so much to Dr. James and Gary Falsitano. This was a wonderful hour filled with lots of information. So thank you for spending the time with us.
Thank you so much for having us.
Yeah, thanks everyone for coming on. This is very gratifying to see so many people come on and learning about food allergies.
Have a wonderful day, everyone. Thanks again for joining us.
Bye-bye.
Thanks, everyone. Bye-bye.